Hello, I'm Hannah Donnett with the Collaborative on Health and the Environment. Change is bringing you the latest environmental health science through our partnerships, calls, webinars, science serves, publications, and social media. I would like to welcome everyone to the sixth webinar in our Generation Chemical Partnership series, which is titled Endocrine Disrupting Chemicals and Maternal Reproductive Health Impacts. Our moderator today is Dr. Jean Conry, President-elect of the International Federation of Gynecology and Obstetrics. We will leave time following the presentation for a brief Q&A session. You may type in questions to the Q&A feature available on the menu bar at the top of your window at any point during the presentations. After the presentations and panel discussion, our moderator will read out questions for our speakers to respond to. We'll get to as many comments and questions as we can during the Q&A period. Audience members will also have access to the chat feature and are encouraged to engage with our speakers during the webinar. For those of you who have called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. For this webinar is scheduled to last for 70 minutes and is being recorded for our call and webinar archive. With that, I would like to introduce Dr. Jean Conry. Dr. Conry is President-elect of the International Federation of Gynecology and Obstetrics, a professional organization with 132 member societies from around the globe. She was the 64th president of the American College of Obstetricians and Gynecologists, a membership organization representing over 57,000 obstetricians and gynecologists. She chairs the Women's Preventative Service Initiative, a United States coalition of national health professional organizations and consumer and patient advocates with expertise in women's health. WPSI develops, reviews, and updates recommendations for women's preventative health care services. In 2013, she introduced the National Maternal Health Initiative to reduce maternal mortality and improve health before, during, and after pregnancy. Dr. Conry has led national policies on the important role of reproductive health in the environment and was awarded the Environmental Protection Agency Pacific Southwest Region Children's Environmental Health Champion Award. She's a board member of the Forum Institute, a nonprofit organization devoted to improving children's health by addressing preconception through infancy, particularly the relationship between health and the environment. For 28 years, Dr. Conry was a practicing obstetrician gynecologist at Kaiser Permanente, the largest health maintenance organization in the United States, where she served in leadership capacity. She currently serves as president and CEO of the Environmental Health Leadership Foundation. She received the Visionary Leadership Award from the University of California and the United States House of Representatives recognition for accomplishments in women's health. Dr. Conry earned her medical degree and a completed residency at the University of California, Davis. She served as an associate clinical professor at the University of California, Davis. She has a PhD in biology from the University of Colorado. She has been awarded honorary fellowship to the Taiwan Association of Obstetrics and Gynecology, the German Society for Gynecology and Obstetrics, and the Society for Obstetricians and Gynecologists from Canada. We're so happy to have you, Dr. Conry, and now I'd like to turn it over to you.
Thank you so much, Hannah, for inviting me to be part of this incredible webinar series. I really want to invite and welcome everyone because we're going to be talking about endocrine disrupting chemicals and maternal reproductive health impacts, which is near and dear to my heart. Today, we have some of our global leaders who are experts in women's and newborns' health. As an obstetrician gynecologist, I know how important it is to understand the physiology of reproduction, to understand health care disparities, and really to understand the important role of medical organizations and societies as being a voice for maternal fetal health. Historically, we viewed the placenta as almost an absolute barrier to toxics and to contaminants. In fact, scientists used to think that the placenta shielded a fetus from the environment. And now we know that that is not true. We know that there are critical times of development when tissues, organs, vessels are all developing and are exposed to chemicals that can have long-term impacts on the health of the fetus, on the child, and in fact on future generations. We also know that chemicals, pollutants, and pesticides cross the placenta as readily as residues from cigarettes, alcohol, and medications. We do have a long history about talking of alcohol and tobacco. Today, you're going to hear people really our leaders talk about important effects of the common chemicals. In fact, FIGO has called this statement that babies are born pre-polluted an important part of our understanding of women's health and fetal development. As clinicians, we know that we have major roles in global women's health. Our first role is in education, so that clinicians and patients understand the important role of environment. We also are important in advocacy because we have to compare notes with our member organizations, our fellow organizations, and the leaders, divisions of ministers of health and the environment, and non-government organizations. And then finally, it is the research like you're hearing today that guides all of our information so that we can amplify these recommendations. We've got, as you see, many important societies here. Endocrine Society, FIGO, the Voice for Women's Health, is the International Federation of Gynecology and Obstetrics, the International Federation of Fertility Societies, and as you've heard, the Program on Reproductive Health and the Environment. One final comment for me, my aha moment really came when I understood that the way pharmaceuticals come to market, which is what a clinician's entire exposure is, relies on safety and efficacy. There are research studies that take place. You're going to hear today that that's not the case with the chemical industry. Chemicals are put on the market without understanding any of the research, the impact on maternal fetal health, and that's critical for long-term health care. Today we have Dr. Julia Warshawski, Dr. Svira Wickstrom, and Dr. Ning Ding, who will be discussing toxic environmental exposures and reproductive health impacts. I'll introduce all three speakers, and then we'll go on to hear each of their very important comments. Our first speaker will be Dr. Julia Warshawski, who has focused her research on characterizing exposures and reproductive and developmental health impacts of endocrine disrupting compounds that are commonly found in consumer and personal care products. She's identifying opportunities to reduce exposures and is particularly investigating vulnerable populations. She is a research scientist in epidemiology and biostatistics with the Safer Alternatives Assessment and Biomonitoring section at the California Environmental Protection Agency. She conducts biomonitoring studies of air pollution, chemical exposures, and health impacts. Dr. Warshawski earned her master's in public health and her PhD in environmental health sciences from the University of California, Berkeley School of Public Health. Our second speaker is Dr. Svira Wickstrom, who is an MD PhD. He is a consultant in pediatrics, and he has a PhD from Uppsala University, Sweden in 2011. His recent epidemiological research is based on the Swedish SELMA pregnancy cohort under the lead of Professor Carl Gustaf Bornhag. The study investigates associations between suspected endocrine disrupting chemicals, including perfluoroalkyl substances and chemical mixtures in several outcome domains during pregnancy and offspring of childhood. Dr. Wickstrom is the sub-study PI for investigations on pregnancy outcomes as well as childhood growth and metabolism. And then finally, we welcome our third speaker, Dr. Ning Ding, who is a PhD, Master's in Public Health. She's a postdoctoral research fellow in the Department of Epidemiology at the University of Michigan School of Public Health. She earned her PhD and Master's in Public Health from the University of Michigan. Her research under Dr. Sung-Kyun Park's mentorship focuses on the effects of endocrine disrupting chemicals such as perfluoroalkyl and polyfluoroalkyl substances on women's health. She applies advanced statistical approaches to investigate the joint effect of chemical mixtures on adverse health outcomes in women. We're lucky to have all three of these speakers today. Please, Dr. Warshawski, the floor is yours.
Thank you. Can you hear me okay?
Perfectly.
Great. Let me just minimize my people here. Okay, so I am Julia Warshawski. I'm really excited to be here to talk with you guys today about a review paper that I led on heightened susceptibility during pregnancy with respect to women's health. So how physiological changes and chemical exposures during pregnancy can impact, and I'm hoping this presentation will provide that you'll hear following mine, which will further highlight critical periods of women's health across the lifespan. My current affiliation, as Jeannie said, is at the Office of PA, and you can see my contact email here, but the work that I'll be presenting today was completed at the University of California, San Francisco's Program on Reproductive Health and the Environment, or PRE, which is housed within the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF. So before I dive here's an outline for the structure of my talk. I'm gonna on how it affects exposures. I'll talk about what we found, as well as, and then I'll end with some conclusions, including recommendations for research and policy implications. So pregnancy is this unique period of rapid biological changes that really dramatically transforms maternal physiology to accommodate the developing fetus. The changes may not be quite as drastic as Ariel's transformation to a human, but they are extreme and profound nonetheless. So first, the placenta is this powerful new neuroendocrine organ that forms and invades maternal tissues and blood vessels to redirect blood flow and nutrients to the developing fetus over the course of pregnancy. A complicated web of changes to the vascular system also occurs to increase blood flow and increase the total circulating blood volume by over 50% over the course of pregnancy, despite initial decreases in blood pressure. Maternal metabolism switches from glucose to fat to preserve as much glucose for transfer to the fetus as possible, because the fetus needs progressively more glucose to grow as gestation continues throughout pregnancy and into the third trimester. So pregnancy can be thought of as a physiological state of progressive insulin resistance, or a pre-diabetic condition in that regard. The breasts undergo their third stage of lifelong development during pregnancy, which began in utero, continues in adolescence, and then is ultimately completed through pregnancy and breastfeeding as the mammary glands differentiate and prepare for milk production. And then the endocrine system largely orchestrates many of these changes through a tightly coordinated and complex series of molecular signaling pathways across the maternal, placental, and fetal unit. So these rapid physiological changes essentially move women closer to disease thresholds and into a borderline disease state, as one of our senior co-authors on our review paper, Amy Padula, put it, to which women must adapt and overcome biologically in order to maintain their health and the health of their pregnancy. So for example, insulin production in the pancreas has to increase by over 200% to overcome the progressive state of insulin resistance that increases across pregnancy as fetal demands for glucose increase. Blood pressure has to decrease, at least initially, despite cardiovascular changes that would normally result in a blood pressure increase. And that's due in part to a sustained favoring of systemic vasodilation and an overriding of vasoconstriction throughout pregnancy, which is really largely driven by the placenta and the remodeling of maternal blood vessels, as well as the release of pregnancy and placental hormones. And reproductive and pregnancy hormones like estrogen, progesterone, and placental hormones like HCG have to increase exponentially and then sustain very high levels throughout pregnancy to orchestrate a lot of these changes. So failure to meet these demands and overcome these physiological constraints can lead to a series of maternal health complications and biological changes that can further impact maternal health across the lifespan. It can lead, they can lead to pregnancy-induced hypertensive disorders, which include a range of conditions that are sometimes thought of on a spectrum or a continuum, with pregnancy-induced hypertension or gestational hypertension at the core. And that's defined as the new onset of high blood pressure or hypertension during pregnancy or after 20 weeks of gestation. Preeclampsia is essentially gestational hypertension with another systemic symptom, such as proteins in the urine, which signals kidney damage. The HELP syndrome is more rare and severe, and eclampsia, which is the very rare and severe progression of preeclampsia that presents with additional stroke and seizure. Gestational diabetes can arise when maternal insulin levels are not sufficient to meet the increased metabolic demand during pregnancy and to overcome that needed 200% increase in insulin production. And then breast cancer risk can also be potentially influenced by changes to breast tissue composition and morphology during pregnancy, which is largely regulated by reproductive hormones like estrogen. And pregnancy-associated breast cancer is an even more rare form of breast cancer that's diagnosed either during or within the first year of pregnancy. And it also has the worst survival prognosis, so I've included it here. But together, these maternal health complications and breast cancer contribute to a significant proportion of women's health issues globally. Preeclampsia and other pregnancy-induced hypertensive disorders are the leading cause of maternal mortality and morbidity worldwide, affecting 5 to 10% of pregnancies worldwide, with 25% increases seen over the last 20 years, and a 5-fold increase in severe preeclampsia risk among young women in the United States, which I think is a concerning statistic. Gestational diabetes mellitus, GDM, affects an even higher percentage of pregnancies worldwide, also with significant increases in past years and expected increases in coming years. Breast cancer remains a leading cause, the leading cause of cancer mortality worldwide, with pregnancy-associated breast cancer contributing to a significant proportion of the total incidence among younger women, and with incidence they are rising alongside global trends in delayed childbearing. And these maternal health complications, they share common pathophysiologies and common complex risk patterns with breast cancer. So for example, preeclampsia and GDM are risk factors for one another during pregnancy that also increase risk to future metabolic and cardiovascular disease in the mother, which can then also contribute to breast cancer risk later in life. But these are each multifactorial diseases that have complex and largely unexplained disease etiologies. And that really begs the question of whether environmental factors may be playing some role in these trends. And it's true that pregnant women are exposed to thousands of environmental chemicals on a daily basis, from personal care products like fragrances, nail polish and dental floss, to food products, including packaged and processed foods and water bottles, to building and flooring materials, as well as common everyday household products like furniture, shower curtains, and so forth. Some of the chemicals you may have heard of include phthalates, BPA or bisphenol A and other phenols, per and polyfluoroalkyl substances or PFASs, polybrominated diphenyl ethers, polychlorinated biphenyls and other flame retardants, pesticides like DDT and DDE, and metals like lead and arsenic. And we're concerned about these chemicals because they are biologically active compounds that can interfere with the molecular signaling, which drives a lot of the physiological changes we expect to see during pregnancy. And it's important to remember that pregnant women are also exposed to multiple chemicals at any given time, which can then have cumulative effects on reproductive and developmental health. It's also important to recognize that physiological changes during pregnancy can increase exposure to chemicals during pregnancy, as well as their associated health risks. So for example, lead accumulates in our bones across our lifetimes, and it's then mobilized during pregnancy with the release of calcium. So not only does that increase our risk of exposure, but it can also induce hypertension and increase risk for developing other maternal health complications. But most environmental chemicals have not been well characterized with regard to maternal health. And most of the research currently on the exposome during pregnancy, which is defined as the totality of external and internal exposures during the pregnancy period, has largely focused on fetal effects rather than maternal effects. So we sought to review the current epidemiologic literature on chemical exposures during pregnancy and risk of preeclampsia, gestational diabetes, and breast cancer during or after pregnancy. We performed a structured search of PubMed literature in May of 2018, restricting to studies that were published since 2000 and using mesh terms for peer-reviewed literature in English. Our inclusion criteria were defined as maternal exposures and maternal outcomes, where maternal exposures are environmental chemical exposures during pregnancy or within 2 years preceding conception for persistent compounds. And this was a qualitative analysis that was intended to be a structured scoping and a narrative review rather than a quantitative approach, and that's because of the large volume and breadth of studies. And we published our search terms you see here in the paper so that this search could be repeated in the future and so that our search was transparent. So from this search, we identified a total of 64 epidemiologic studies since the year 2000 that examined these associations between chemical exposures and our outcomes of interest. We found 37 on preeclampsia, including high blood pressure and hypertension as clinical indicators of PE, 24 on gestational diabetes, including gestational impaired glucose tolerance or IGT, and 3 on breast cancer. The studies covered a wide range of population sizes from 58 to almost 300,000 study participants. The majority of preeclampsia studies included a small number of cases, about 25 to 85, and so more often used a case control study design as a sampling strategy, whereas the majority of GDM studies used cohort rather than case control study designs. So while our descriptive approach precluded rigorous quantitative evaluation of study quality and risk of bias, like you'd see for in a meta-analysis or a systematic review, we did identify several common sources of epidemiologic bias that are important to consider. So for example, most studies conditioned on live birth data from pregnancy cohort studies or birth records, which can introduce selection bias known as live birth bias from the exclusion of participants who would have become preeclampsia or gestational diabetic cases had they not experienced earlier fetal loss, which can underestimate risk. Also, the studies that we reviewed really varied substantially by the method of exposure assessment. Some measured chemicals directly in biological or environmental samples like urine, blood, or drinking water, while others were modeled, which can often make it more difficult to detect an association if one exists. The studies also differed in how they corrected for urine dilution and chemical lipid partitioning in serum, which is also a source of potential bias. Out of the 37 studies on preeclampsia, there was a pretty decent spread across pollutant types. Some highlights include a modest increasing association between high PFAS exposure levels and preeclampsia that was found in a highly exposed US population, but not in a population with lower background PFAS exposure levels. Results were mixed for the organochlorine pesticides, DDT and DDE, with both increasing and inverse or null associations reported. High DDT and DDE exposure levels were associated with increased risk in African but not US populations, which may indicate greater baseline vulnerability in South African women as a result of underlying health disparities. And there was also some evidence of increasing association between BPA or phthalates and preeclampsia, but major differences between those studies made comparability very difficult. There were differences in the sampling matrix and timing of measurements, with exposure and outcome assessed across at different time points throughout pregnancy. There were also differences in the method of urine dilution correction and so forth. Interestingly, increased preeclampsia risk was associated with lead, which has been reviewed well by others previously, but we also saw an association with cadmium and to a lesser extent mercury and arsenic, although there were issues with study comparability there as well. But I think that suggests the importance of examining metals in combination in future research on preeclampsia. Some preeclampsia studies in more recent years have begun to look at chemicals in combination and have begun to apply statistical methods that assess longitudinal data and nonlinear exposure response relationships. And they've also more readily begun to adjust for important risk factors like family history of preeclampsia and or diabetes, which was not previously a routine thing. Most of the 24 studies on gestational diabetes focused on persistent pollutants with a smaller number on non-persistent chemicals. There was some evidence of increasing but nonlinear dose response relationships found for PCBs or PBDEs and GDM risk, but results were mixed. And there was, again, limited comparability, unfortunately, due to variable study locations and study populations, big differences in exposure levels, and the timing of measurement, which was roughly divided across pregnancy, kind of like it was for preeclampsia studies, ranging from just before birth to soon after delivery. Of note, though, PFASs were associated with GDM or IGT risk in three studies across diverse locations and study populations. Null associations were largely found for non-persistent chemicals, although an increased risk was identified with occupation as a cosmetologist or manicurist. All 7 of the metal studies looked at arsenic, but the matrix of analysis for arsenic varied substantially across those studies. Increased GDM or IgT risk was associated with arsenic, for example, in water and in non-urinary biomatrices like blood, meconium, and nails. And there was some evidence of an increasing dose-response relationship there, as well as some evidence that the first trimester may be a potential window of vulnerability. But like with PE, more of the recent studies on GDM have begun to apply advanced statistical methods for analyzing mixtures and nonlinear dose-response relationships. But more important confounders like family history of diabetes and or hypertension, as well as weight gain during pregnancy, were not typically included. We only identified 3 studies on environmental chemical exposures during pregnancy and breast cancer, all of which evaluated persistent compounds, and that's partly due to the length of follow-up required for breast cancer studies, given the long latency period of that disease. The 3 studies we found evaluated PCBs, PFAS, and DDT or DDE in 2 study populations. One was in Europe and one in the United States. The European study found inconclusive results for PFAS and breast cancer risk, while the US studies found some evidence of increased risk associated with PCB or DDT exposure. In conclusion, we found through this review sufficient evidence to justify concern about the potential impact of chemical exposures on women's health, but the substantial variation that we saw in study design, in the method and timing of measurements, and in analytical and our ability to interpret the literature. Further research resolving some of these inconsistencies would really strengthen this body of knowledge going forward and would facilitate potential systematic review going forward. Specifically, efforts to incorporate deliberate selection of biomarkers and the timing and method of measurement, I think would be really beneficial. And a more consistent analysis of confounders, cumulative exposures, and nonlinear associations going forward is also warranted and seems to be where the research is headed. We also identified some general research strategies that could facilitate this research further. One is leveraging existing epidemiologic studies to evaluate maternal outcomes. That is taking advantage of pregnancy and birth cohorts that are already underway, which have focused more intentionally in the past on fetal outcomes. Another general approach is to incorporate more molecular biomarkers and clinical indicators to further strengthen the epi research. So for example, there's a lot of compelling research on PFAS and subclinical measures of GDM. Finally, regardless of the current state of literature, we concluded that pregnancy should be regarded as a critical period for women's health on the exposome. And this not only has implications for our collective research, but also for policy and the way that we regulate chemicals, as well as the way we consider susceptibility and vulnerability in risk assessment. So, for example, pregnancy should probably be considered a sensitive window for women in the calculation of human variability and vulnerability factors in chemical risk assessment. So in order to be more protective of the entire population in the same way that we think about protecting the developing fetus and children. And here's a blog we wrote at PRE translating our review paper for a broader audience and highlighting some of what I've touched on today. And I've included a link to that here, as well as a link to the citation for this paper. And so I'll end there by thanking my co-authors at PRE and funders on this project. And I look forward to more discussion on this topic. Thanks so much.
Thank you so much, Dr. Warshawski. Our next speaker, Dr. Vikström, will be pulling up his slides momentarily, but I wanted to remind everyone to put in your questions in the Q&A, and we will get to them after our panel discussion and the presentations at the end of the webinar. Thank you so much. And there, Dr. Vikström, do you want to take it away? We'll need you to unmute too, Dr. Vikström.
Sorry, I happened to double click on it. Um, Thank you very much, Julia, for your talk, and Professor Conrad for introducing me already. I'm very happy for this opportunity to present one of my research interests, namely PFAS chemicals and women's reproductive health. I will actually present two studies, of which one is brand new, published just a few weeks ago. Here are my disclosures for today's talk. I have no conflicts to declare. However, I want to make clear that although I am primarily a clinician and a clinical researcher, I am not an OB/GYN doctor. I'm a pediatrician and adolescent psychiatrist. I would also want already to mention the local research group at Karlstad University, Sweden, working with this pregnancy cohort since 2007. For the present studies, my colleagues mentioned here have been very important, so I would like to thank them. This pregnancy cohort that I'm working with is named SELMA, which stands for Swedish Environmental Longitudinal Mother and Child Asthma and Allergy Study, since it was launched as an asthma study, but already until recruitment, it was developed in something much bigger. The acronym is also a dedication to a person that lived nearby. You can see her here on the picture. And that was Selma Lagerlöf, the first woman to win the Nobel Prize in Literature. This study focuses on early pregnancy exposures to known or suspected endocrine disrupting chemicals and outcomes during pregnancy, at birth, and during childhood in several domains. Such domains, they include women's reproductive health, birth outcomes, growth during childhood, asthma and allergy, sexual development, alterations in the metabolome, and cognitive development, including language, represented on this picture. We have studied them, we have followed these children until 7 years of age. And I have been responsible for large parts of the study examinations and data sampling within the study. We are today collaborating with several universities, but especially Lund University in Sweden and Mount Sinai in US. So among these chemicals I got interested in are the PFAS. I find them impressive, but not always so essential compounds that are hydro and oleophobic, as illustrated by the droplets on this slide background here. This means that they make everyday products more resistant to stains, grease, and water, which is, of course, very convenient. PFAS are used a lot in food contact materials, electronic industry, production of plastics and rubbers, cosmetic, lubricants, ski wax, polish, waterproof clothing, stain-resistant fabrics, non-stick materials, firefighting foams, and so on. And these compounds are very problematic since they are extremely persistent in the environment, and they build up in, for example, groundwater and marine food chain. So they accumulate. So therefore, we are, in summary, all of us exposed to PFAS, primarily through our diet. Seafood is one of the important sources. In our SELMA study, we measured 8 PFAS compounds by 10 weeks of gestation. We believe this is early enough to avoid some confounding from renal function and pregnancy-related changes in the circulation. Remember also how long half-lives are of these chemicals. So single analysis should be good measure of long-term exposure, I think. The serum levels in SELMA were generally quite low from an international perspective. But they were they were identified. 6 of them were identified in 99% of the women. Until now, I have published 3 closely related papers on PFAS and pregnancy. First on preeclampsia, then on fetal growth, and finally on miscarriage. I will go through our data on preeclampsia here. We heard about it already from Julia. Preeclampsia is a disorder during the second half of pregnancy, defined by hypertension and protein in the urine. Affected women may develop headache, nausea, blurred vision, abdominal pains, edema. The aim of our study here was to investigate any associations between early prenatal serum levels of these 8 PFAS compounds and preeclampsia during the same pregnancy. And why did we study these associations? One reason is, as pointed out by Julia in her paper, that research on prenatal exposures have focused very much on the fetal outcomes and less on the maternal outcomes. I regard an association between PFAS and preeclampsia quite plausible. When I was a medical student more than 20 years ago, preeclampsia was called the disease of theories. And this is actually still true. The proposed mechanisms are interesting also in relation to PFAS. And as a matter of fact, the known risk factors do explain only a small portion of preeclampsia cases. So therefore, I find it important to find new risk factors. We also have this established relation between PFAS and birth weight, which is possibly placenta related. And I find that also indications that the present association should be studied. And we know that PFAS may influence the immune system and increase oxidative stress. Another reason to study this association between PFAS and preeclampsia is, of course, the clinical importance. We already heard that this is common. It's a major cause of maternal and fetal morbidity, responsible for more than 10% of maternal mortality worldwide. In the long term, it also increases the risk of cardiovascular disease in the mother. And as a pediatrician, I am confronted with the consequences to the fetus, including mortality, intrauterine growth restriction, preterm birth, developmental impairments. So there are reasons to study this. What we did was that we analyzed these serum samples from 10 weeks of gestation. We collected maternal diagnosis from medical birth, Swedish Medical Birth Register. Blood pressure and urinary albumin are routinely measured at each visit in our free and nationwide antenatal care program. Preeclampsia was diagnosed according to a blood pressure increase and accompanied by protein in the urine. I performed a compound by compound analysis and adjusted this for parity, age, body weight, and smoking, which we know are clearly associated with the risk for preeclampsia. So the results are in crude analysis. We saw significant associations with PFOA, PFAS, and the PFNA substance. Then with full adjustments for the covariates I mentioned, we had significant associations with between preeclampsia and PFAS and PFNA. Although it was not significant, I am also very concerned about PFOA. In the highest quartile of exposure, we had borderline significance here, and I do not want to rule out the matter of low statistical power in this question. Interestingly enough, we saw higher risk estimates in analysis restricted to primiparous or during the pregnancy nulliparous women. The risk increase was in the size that doubling of PFAS or PFNA was associated with increased risk of preeclampsia of about 40 to 50% respectively. I do want to mention that, of course, this was not a large sample of cases. There were 64 cases of preeclampsia among these 1,773 women in the study group. But still, we saw this clearly significant results. Here you have a table that tells the same thing, the crude analysis here in the left column and the adjusted analysis in the right column. This is per 1 unit increase in log base PFAS level, that is doubling of exposure. Below you have the nulliparous, that is primiparous after this delivery. Of course, a small sample. So in conclusion, we saw higher serum levels of PFAS, PFNA, and possibly PFOA at 10 weeks were associated with preeclampsia. And importantly, the risk estimates were highest among primiparous women. And to give a perspective on this, PFAS levels in the 4th quartile, as compared with the 1st quartile, was related to an odds ratio for preeclampsia of the same size as primiparity. And that we all know is a well-established and major risk factor. I would like to continue to the brand new paper published some weeks ago regarding another outcome measure, actually prior to preeclampsia. I will also share the link to it later here in the chat. So to the miscarriage question here, pregnancy loss before 20 weeks of gestation. The aim here was to investigate whether maternal exposure to PFAS in early pregnancy is associated with unexplained sporadic first trimester miscarriage. I want to emphasize unexplained and sporadic. So why did we study this? The same reasons as in the previous paper here apply. A plausible association, I think. This is like preeclampsia, multifactorial background to this, and a large number of first trimester sporadic miscarriages are unexplained. Of course, genetic etiology is very important, but there is still a large number of unexplained cases. We also know that miscarriage, preeclampsia, and reduced fetal growth, they share a relation to placental dysfunction. So, and we already showed the relation to preeclampsia and to reduced fetal growth. So this was a third outcome measure to study within the same dimension, I think. There is also experimental support for effects from PFAS on placentation. And of course, this is also a clinically important matter. Miscarriage is common. It ends about 10 to 20% of identified pregnancies. Most is done during first trimester, and we know that this causes both physical and emotional suffering, and the suffering both for the woman and also for couples, for the men. This study was also embedded in SELMA study. Blood samples were drawn, as I told you, by study recruitment. We excluded all women that previously had more than 3 consecutive pregnancy losses or kidney disease. And we also excluded all miscarriages that were obviously explained by predefined maternal or fetal conditions, like identified malformations or chromosomal abnormality, or severe uterine conditions not compatible with successful pregnancy. We studied miscarriages before 13 weeks of pregnancy and adjusted the analysis for age of the mother, for parity, and for tobacco smoke during pregnancy. 78 women with sporadic unexplained miscarriage during the second half of the first trimester were found in our cohort, and we compared them to the live birth controls. And for PFOA, we saw that a doubling of exposure, like in the previous study. Here it is corresponding actually to an increase from the 25th to 75th percentile of exposure that was associated with an odds ratio for miscarriage of close to 1.5. Here I show an analysis per quartiles of exposure and adjusted for the same potential confounders. There was a significant increase in risk for miscarriage within the highest quartile of PFOA as compared with first quartile, and similar, very close to significant pattern was observed for PFNA over here. So in conclusion, we actually now add an association between first trimester PFOA levels and the increased risk for sporadic miscarriage during the second half of the first trimester to the associations with preeclampsia, as well as lower birth weight that we already have shown in our study cohort, our pregnancy cohort. I would like to emphasize that the present study may only represent sporadic and clinical miscarriages during a period of early placentation. These miscarriages occurred between the 6th and the 12th gestational week. And I think that the emerging indications on PFAS effects on the human reproduction outcomes, they suggest shared mechanisms here. Miscarriage, preeclampsia, and impaired fetal growth, they share in common the association with abnormal placentation and placental oxidative stress. There are interesting experimental findings that PFAS compounds may disrupt placental endocrine function and affect human placental trophoblast with effects on placental development. PFAS compounds may also increase oxidative stress, which is shown, for example, in human first trimester trophoblast. So thank you for listening, and I would also like to recommend the previous talks in the webinar talks in the Collaborative on Health and Environment series here on the talks on PFAS science and policy. I learned very much from them. Thank you for listening so far.
Great, thank you so much, Dr. Vikström. Dr. Ning, if you want to pull up your slides, and Ning will be ready to share those in just a moment. And please put your Q&A or questions in the Q&A. Take it away, Dr. Ding.
Can you hear me?
Yes, we can hear you.
Cool. Let me pull up this. Hi, my name is Ning Ding, and I'm a postdoc research fellow in the Department of Epidemiology at the University of Michigan School of Public Health. And first of all, I just wanted to thank you for inviting me to present today, and thank Jean and Hannah for the details and logistics of the presentation. And I'm going to be discussing my dissertation work titled Perfluoroalkyl and polyfluoroalkyl substances, which I will refer to as PFAS in this presentation. And I will talk about the effects of PFAS on women's health, but from a different perspective, with a focus on reproductive aging. I will first cover a brief background into the female reproductive aging process. The ovaries are responsible for the production of the hormone estrogen, which decreases with aging. And estrogen is a major hormone responsible for affecting physiologic changes in a woman's body. And dropping estrogen levels are responsible for decreased fertility rates and depleted ovarian reserve. So then is menopause. It marks the end of reproductive lifespan. And menopause is clinically defined as women haven't had a menstrual period for at least 1 year. And we are now expanding our discussion to focus on menopausal timing or age at menopause and its associated health risks. Women will likely experience natural menopause between age 45 and 55 years, with a median age of around 50. But some women reach this phase in their 30s or early 40s, while others in their 60s. And I want to highlight here that both earlier and later onset menopause are not good things for women's health. For example, earlier onset menopause can affect women's overall health, such as mortality rates, cardiovascular health, bone mineral density, and psychological functions. On the other hand, later onset menopause was associated with breast, endometrial, and ovarian cancer. So it is important to find risk factor related to age and menopause. Now that we've seen the health problems caused by earlier and later onset of menopause, let's look at several factors that are related to age and menopause. And these include race, mother's age and menopause, socioeconomic status, obesity, exercise habits, diet, smoking, and hysterectomy and oophorectomy. And it is obvious that more research needs to be done about habits and traits that may impact the overall schedule. So factors that are related to age and menopause are not well understood. And it is increasingly recognized that the endocrine disrupting chemicals, or EDCs, may also play an important role. And they include phthalates, pesticides, and many other persistent or non-persistent chemicals. And PFAS are an emerging group of potential EDCs. And Sphere has a great introduction on PFAS, so I will go through this briefly. And they are a family of 100% man-made chemicals. And they're commonly classified into different categories. And some of these categories include perfluoroalkyl carboxylates and perfluoroalkyl sulfonates. And among them, PFOA and PFOS are commonly detected compounds. And these chemicals are virtually indestructible with the nickname forever chemicals. And people can be exposed to these chemicals through use of consumer products, including non-stick cookware and food packaging materials, waterproof clothing, furniture, and many personal care products, such as dental floss. Drinking water is also a major source of PFAS. And a recent study has estimated that more than 200 million Americans, which are around 2/3 of the population, consume drinking water contaminated by PFAS. Therefore, it is critically important to evaluate the potential health effects of these chemicals. So as a graduate student, I became interested in the potential effects of PFAS on women's health. And previous studies have suggested that the ovaries may be a potential target for PFAS. And then we conducted a comprehensive review, and we found that higher PFAS were associated with later menarche, irregular menstrual cycles, and reduced level of estrogens. And we also found that ovarian folliculogenesis, which is the proliferation and development of ovarian follicles, as well as steroidogenesis, which is the production and secretion of sex hormones. And both of these are potential target of PFAS toxicity. And let's look at ovarian folliculogenesis as an example. PFAS may have an impact on folliculogenesis starting from the second and third trimester of pregnancy. And it goes through puberty and until menopause. And PFAS can lead to follicle atresia or cell death through activation of nuclear receptors, oxidative stress, or get involved in the gene, the meiosis of oocytes, or disruption of nutrient supply between granulosa cells and oocytes. And our findings suggest that PFAS may accelerate ovarian aging by decreasing the number of follicles and oocytes. Although previous study examined the association between PFAS and ovarian functions, we identified several research gaps in the current literature. And previous studies suggest that the non-menstruating women had higher serum concentration of PFAS compared to menstruating women. So it is unclear whether PFAS exposure is the cause of earlier natural menopause, or the stop of menstruation leads to reaccumulation of these chemicals in women. Hence, the evidence remains insufficient to infer a causal relationship because previous studies are mostly cross-sectional studies, which are subject to reverse causality bias. Furthermore, women are exposed to PFAS on a daily basis. It is also important to evaluate the joint effects of PFAS mixture on reproductive aging, in addition to single associations. Therefore, we use longitudinal data from the study of women's health across the nation, or SWAN, to investigate the effects of PFAS on menopause. And the study was initiated in 1996 and 97, and at baseline, 3,302 women were enrolled from 7 study sites across the United States. And they include white women from all sites, Black women from Boston, Chicago, Southeast Michigan, and Pittsburgh, Chinese women from Oakland, Japanese women from Los Angeles, and Hispanic women from Newark. And SWAN has approximately annual or biannual follow-up visits. The SWAN multi-pollutant study, or SWAN MPS, was initiated in 2016 using data from the third SWAN visit in 1999 to 2000, which is the baseline for SWAN MPS. And the study was designed to examine the associations between multiple chemicals and health outcomes. And we have a subset of 1,400 SWAN participants from 5 sites, as shown in orange color on the map. And to evaluate the effects of PFAS on reproductive aging, we need information on PFAS exposure in women reaching the end of their reproductive life. So in the first place, using the SWAN MPS data, we describe the distribution of PFAS concentrations in midlife women and also identify their determinants. A total of 11 PFAS were measured in serum samples. And among these chemicals, we have 4 with detection rates less than 40%, as shown in red color. And all other PFAS have high detection rates, and they are included in the further analysis. And we also identify determinants of PFAS in these women. For example, Black women had higher PFAS concentrations compared to other racial ethnic groups. And we also found that menstrual bleeding and parity were associated with lower PFAS concentrations. And these suggest that blood loss during menstruation and childbirth may serve as an important elimination pathway in women. And other determinants include age and consumption of salty snacks, for example, popcorn and potato chips. Furthermore, we also explored the temporal trend of PFAS between 1999 and 2011 in a subset of 75 women. And we observed decrease in PFOA and PFAS, which is consistent with the phase out of these legacy compounds since 2000. PFHXS also had a small amount of decrease, but the changes were not significant. While PFNA has significant increase, especially after 2005. Although PFNA is phased out of use in 2010, it is still ubiquitously found in drinking water in the United States. Now that we've covered PFAS and their determinants, let's further look at the association between PFAS and incident natural menopause. Incident natural menopause was defined as amenorrhea for at least 12 months, not due to hormone therapy or surgery. And we used Cox proportional hazards model with adjustment for a comprehensive list of confounders. And we calculate hazard ratios of incident natural menopause. PFAS concentrations were categorized into tertiles, shown as T1, T2, and T3. And we found that higher PFOA and PFAS were associated with earlier natural menopause. For example, women with the highest tertile PFOA concentrations had a hazard ratio of 1.31, which means 31% more likely to reach their natural menopause compared to those with the lowest tertile. And we also calculate median age at menopause. And using that, we found that 31% could be interpreted as 1.1 years earlier natural menopause. PFAS is similar to PFOA, and women with the highest tertile had 0.9 years earlier time to natural menopause. And we also calculate the combined effects of PFAS mixtures. To identify subgroups with different concentrations, we use the unsupervised learning method, k-means clustering. And this method was used to find an optimal number of clusters in order to minimize within cluster sum of squares. So in this way, women with similar concentration profiles were more likely to be classified into the same group. And we use multiple criteria to find the optimal number of clusters, which results in 4 clusters, including the low group, in which women had the low overall concentrations, low medium group, medium high group, and high group. Women in the high group had the highest overall concentration patterns. And using results from k-means clustering, we created adjusted survival curves by clusters of PFAS mixtures and calculate the median time to natural menopause. And there are significant differences between the low and high group. Women in the high group, showing brown color, reach their natural menopause more quickly compared to those in the low group, as shown in blue color. And the predicted median age was 52.8 years for women in the low group, while the number decreased to 50.8 years for those in the high group. So we found that the women in the with high overall concentration patterns of PFAS reached their natural menopause 2.0 years earlier compared to those in the low group. And let's recap on what we've spoken about today. The first one is about the endocrine disrupting role of PFAS. These chemicals are potential ovarian toxicants that may accelerate ovarian aging. And the second, we identify race ethnicity as a major determinant of PFAS concentrations. Besides, we also observe decline in PFOA and PFAS suggesting the effectiveness of phase out of these chemicals. And finally, PFAS were associated with earlier onset of natural menopause. And our findings prove that these chemicals still pose significant public health concerns. And I want to highlight here that menopause, even a few years earlier than usual, could have a significant impact on cardiovascular and bone health, quality of life, and overall health in general among women. For example, a previous large cohort studies with an average of 17 years of follow-up, and they found that 2.0 years earlier natural menopause was associated with shorter life expectancy with a hazard ratio of 1.04. And a major follow-up question from our work is about potential health consequences to midlife women. As we all know, menopause is a stage in life. It is not a disease. But we know that many side effects could result from earlier onset of menopause. So it is important to link natural menopause to potential health conditions. And previous studies have also found that the EDCs, such as phthalates and polychlorinated biphenyls, were associated with menopausal timing. So future studies should also evaluate the mixtures of different panels of chemicals. So now we are working on a series of additional projects, including evaluation of different chemicals with reproductive traits and metabolic outcomes, such as body composition and diabetes. And last but not least, I wanted to acknowledge my fantastic mentor team at the University of Michigan and our co-authors, and of course, all the participants in SWAN. So with that, I would like to stop here and open the floor for questions and comments. Thanks.
Thank you. And on behalf of this wonderful panel, I want to thank the Collaborative on Health and the Environment for putting together the panel and the entire series of webinars, because they've been really fabulous. I think we've got time for our panel discussion to have one question each, and then I want to turn it over to Karen and to Hannah to really address all the questions from the audience today. So I'll start with Dr. Warshawski. You did a fabulous job really talking about the complex understanding of diabetes and preeclampsia, which are two of the diagnoses in pregnancy that we're concerned with on a daily basis. I'd like you to look at or address a little bit about healthcare disparities. You said we've got environmental components of health disparities. Can you give us some insight there with regard to environmental exposures?
Yeah, we know there are health disparities in maternal health complications like preterm birth that are pretty well documented. And we also have good evidence showing environmental health disparities in terms of exposure to environmental chemicals, like Dr. Ding also just presented on. And so what's not clear in the literature that we looked at in terms of the epidemiology on environmental chemical exposures during pregnancy and maternal outcomes like preeclampsia and gestational diabetes is how well the environmental health disparities have been assessed for those particular outcomes. And so I think there's some work that can be done there to enhance that part of the literature. Some of the disparities that I think are worth mentioning are, I mentioned an underlying or a higher risk associated between DDT exposure and preeclampsia in African populations compared to other populations, and indicated that might be due to some underlying health disparities. And I think that's a really important potential disparity to continue research on, because there are only a few countries in Africa that have current indoor active use of DDT exposure that's still occurring. In most parts of the world, it's banned or not in use. So the combination of high preeclampsia prevalence in those communities and the underlying health risk and the high exposure levels of DDT, I think are a very important environmental health disparity that we need more information on and potentially more work on to figure out how to reduce those exposures. So I'll stop there, but.
Thank you so much, Dr. Warshawski, for everything you've shared today and for that response. Dr. Wickstrom, I think I've got to call you an honorary OBGYN for the depth of your discussion. I love that you call preeclampsia still the disease of theories, because it still is. And in fact, we hear a lot of discussion on the use of anti-inflammatories and a placental basis. So I really appreciated that you gave a very clear discussion on preeclampsia, the risks to the mother and the fetus, and the exposures, the timing, the cumulative effects, and the role of the placenta. Can you look at some of the previous studies? You know, I know that when we're talking about preeclampsia on a global nature, there's this focus really not from the environmental area at all. But could you look at previous studies and compare that to what you've shared today? I believe the webinar would benefit from a discussion looking at some of the previous studies.
Yeah, actually, thank you very much for that question, Professor Conran. I would like to make a point that there are other exposures, completely other exposures with air pollution, for example, that are quite convincing as a risk factor for preeclampsia. So we already know that environmental exposures, they do matter. When it comes to the field of PFAS, I would say that, well, there are divergent results, but still, even if there are some differences in methodological differences and in results, I start to get convinced that there are associations here, because we have several studies from different populations. I actually made a slide here that I think I can very quickly share. Do you get it?
Yes, thank you.
With these previous studies, do you get that one? Yeah.
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 What a good compilation. Yeah.
From this C8 health project in US, you see that PFOA was associated with preeclampsia. We had a Norwegian study where they saw minor associations. There was the MIREC study. Another Swedish study that actually did not find as strong associations that we did, and they had a larger sample, so everything is not that evident in the same direction. There was another study in Shanghai that also showed associations with preeclampsia. So altogether, I would say that even if there are differences, I would not. I would say that most indicates that this is not a matter of reverse causation. I do not get convinced when people say that this must be some kind of reverse causation matter, because we see it in so different populations with different statistical modeling and with several of these compounds. Was that a kind of answer to your thoughts?
That's perfect. And in fact, I think, you know, in your comments, you said we have a number of risk factors that increase the risk of preeclampsia, but it's not clear that any individual, for example, with hypertension is going to develop preeclampsia. So I think that's the same thing that you're describing here, that there are risk factors, and it gets very complicated on that these are elements that we have to be considering. And it's certainly something I would say most OBGYNs do not ever consider when they're counseling their patients. So I think that's what's very important here. So I appreciate your comments and your entire perspective. And Dr. Ding, this was a very impressive look at PFAS across the entire lifespan. So often we're focused either on ovulation or pregnancy alone, but you really took a lifespan approach. And I know the Women's Preventive Services Initiative in the United States also looks at that lifespan approach, looking at how we can make recommendations on preventive health. I wonder how you would summarize the effect of PFAS across the lifespan for women.
Yeah, this is a really good question. It is concerning that PFAS bioaccumulate, and we know that they are harmful to our health. And based on our review, and biological evidence has suggested that the adverse effects of PFAS on disrupted hormone synthesis and depleted ovarian reserve, as I've already shown you in my slides. An epidemiologic study also indicate the developing reproductive system may be particularly vulnerable to PFAS toxicity in the earliest life stage. I believe Dr. Warshawski and Wingstrom have already talked about these. And previous study also suggests that the PFAS are associated with delayed menarche and irregular menstrual cycles based on our findings. And in addition to that, PFAS may also have an impact on longer time to pregnancy and reduced fecundability based on the most two recent systematic review. And we are currently looking at later life stages, examining the association between PFAS and many reproductive outcomes in midlife women using the SWAN data. And our next step will focus on these sensitive time window of menopausal transition and symptoms and chronic conditions related to reproductive aging. So I think my answer to your question is yes, PFAS may have an adverse effects on ovarian function at different life stages. However, more research needs to be done. In particular, the prospective cohort studies are necessary to infer a causal relationship.
Thank you so much. And I'll turn it over to Karen and to Hannah to address the audience questions. Thank you for everybody today.
Great. Thank you everyone so much for your presentations. I'm going to go through the audience questions. If there are any other questions from audience members, please put them in the Q&A and we will get to them. Dr. Warshawski, is there any study currently funded like the ongoing women's health study to collect and archive the exposomes at various stages in a woman's life?
Yeah, I tried to answer that over the chat. I think there are a few. I think some of we've heard about today that cover parts of the lifespan, critical periods, different critical periods, but I'm not sure of any that's completely comprehensive, from birth to later life, except for maybe the women's health studies, the oldest one or the longest one I can think of, but I'm sure other people on the call may have more and better information about that. But I think the short answer is there are some that look at different parts of the lifespan. I don't know of any that are wholly comprehensive. And that I think is what we're working towards, is how I would answer that.
Great. Dr. Wikström, a participant asked about the short chain PFASs, which have in many cases replaced the longer chain ones. Did you look at any of the end products of short chain PFASs in your studies?
Yes, we did. We did look at maybe the easiest thing for me is to put up the. It is the previous slide. Do you get that one there?
Yeah, we see it.
Yeah. So here are all the compounds that we analyzed. The only one that was really uncommon, I would say, at least less than half of the women, detectable in less than half the women, was this PFDODA. all of these other compounds were more or less in everyone. So you see here that there are some of these, what would you say, newer replacement compounds here, and well, this might be a bit speculative for me, but I would say that epidemiological research will never catch up with the industry when we are talking about these chemicals. I mean, oh, sorry, something happening with my computer here. Dropping connection here. Sorry, I'm really sorry. Do you hear me still?
We hear you still.
Okay, something happened here. What did I start with? Well, if we are waiting for evidence on every single compound, we will just stand by and watch these accumulate in the environment and in human. So I think that we should be really careful and a bit maybe brave when we talk about replacements here, I think.
Yeah.
Just a comment to that on different chain lengths.
Yeah, we had another question for you. Did you look at any associations for preeclampsia or miscarriages with the sum of the measured PFAS? So looking at, mixtures or combinations. Yeah.
No, I did not do that because I think that the sample size regarding at least regarding preeclampsia was too small for that. I did not want to go into such complex modeling with such a small sample. So no. But I think that these results really call for such an approach in future and larger cohorts. Definitely.
Yeah. Dr. Ding, we had two questions. One was about hormone replacement therapy and extending life expectancy in early onset menopause women, and also another on oral contraception and PFAS levels. And can you just comment on both of those?
Yeah, so this is a really interesting point. So women, if they're on hormone therapy, have usually have relatively high estrogen levels. And also the oral contraceptive use, on the other hand, may also, like I just already said about the reverse causality bias, may also have an impact on PFAS concentrations. So the first answer to our first question is about, we need to use prospective cohort to examine the association between PFAS and menstruation and menstruation-related outcomes. That's the first one. And the other about that is women usually don't have exact clean final data of final menstrual period or certain if they go on hormone therapy. So, but I think it's a really good question, and it is possible, but we need to prove that in our study population, whether or not the hormone therapy may extend the life expectancy.
Yeah. Great. We had a couple of questions about policy. One, do any of the panelists have policy recommendations in terms of prioritizing different contaminants for regulations based on your review?
Yeah, I think if anyone don't want to go, I can go first.
Sure.
Yeah, so mine is about PFAS. I think the most dangerous way that people are exposed to PFAS is through drinking water, because it is a major source of these chemicals, which are beyond our control. And our data have already suggested that the voluntary phase out of PFOA and PFAS by industries and government have resulted in reduction of these legacy compounds during the period of 1999 to 2011. I think this is a good example about how restriction or industrial phase outs can contribute to lowering the population-wide exposure levels. So we know that PFAS do not break down in the environment and build up in human tissues. I think that therefore it is important to have regulations and set up early control of PFAS exposure in the general population.
Okay. Anyone else would like to comment?
I would just second that, the call for PFAS, which is getting a lot of attention. So this is nothing new, but you know, there have been recent calls to regulate PFAS as a class of chemicals, which I think is really important for the issues around regrettable substitution and as Fair said, you know, trying to catch up, or we're never going to be ahead unless we think about it in a more proactive and holistic way in terms of regulating them as a class of chemicals.
Yeah, thank you. We also had a question, maybe Dr. Connery, you could answer this one, and Dr. Vikstrom too. How can OBGYNs and pediatricians talk to their patients about minimizing exposures in children preconception, during pregnancy, and throughout the lifespan?
You know, I think it's probably one of the most important questions. What we focused on is first educating clinicians at the same time we're educating the public, because I would say many clinicians do not even know about endocrine disruptors. So our goal is to improve the network around the world about endocrine disruptors and then provide the evidence. As I said in my opening remarks, it's people don't understand how different it is for a pharmaceutical to come to market compared to chemicals. So a lot of docs and I think most clinicians are looking at it thinking, oh, if it's on the market, it must be safe. So dispelling people of that safety understanding is probably the very first step. And then being there to have our major organizations being a voice for this. I just heard from one of my colleagues in the nurse practitioners and nurses have all aligned with an environmental group, and it's extremely important for that. So I would say education, being the amplification for research, and being advocates is where we've got to go. And I would say with the online support that they've got is incredible. The resource there, and Safety Nest, which is an easy online resource, is really critical. So finding those kind of resources for clinicians to share with their patients is key.
May I comment that as well?
Sure, yes, please.
I fully agree with Professor Connery here, especially regarding the education question of education. However, if I would say something more about it, I would say that the next step after education would for me be the regulations. Sometimes I hesitate a bit, maybe because I'm a pediatrician and not an OB/GYN doctor, regarding this counseling of the women and, or couples. As a pediatrician, I know how worried and self-blaming a pregnant couple can be when something happens with the pregnancy. And I do really not want to put more burden or more responsibility on the individual woman by emphasizing the ways for the individual to lower exposure. Of course, it is possible to avoid some of the exposure by avoiding the non-essential, like nice to have products with PFAS. But I think that we should really go for regulations, even if it does not rule out individual counseling. What do you say about that, Professor Connery?
Absolutely. You know, when it came to TSCA reform, ACOG was sitting there at the table trying to improve the Toxic Substances Chemical Act in the United States. But as we've seen with the last 4 years, our environmental laws have been weakened. So I absolutely agree with you that we have to strengthen. That's why we're telling our clinicians they have to partner with the ministers of health and the ministers of the environment as we try to improve regulations, because the regulatory environment is key. But I'm not saying one is better than the other. I think we've got to be going along both paths, being there to lead in a regulatory context. And I think that's why FIGO came out with their very important statement that we need this to take place. We need to look at environmental justice as we discuss this. And I am fortunate enough to live in the European Union a good part of the year and see how great the laws are there in terms of protecting against environmental endocrine disruptors. So I agree completely with what you're saying.
Well, thank you everyone for your presentations and for the discussion and answering questions today. Hannah, I'll turn it back over to you.
Great. Thank you so much, Karen, and to all of our speakers today. We're approaching the end of today's webinar. A video recording will be available on Che's website soon, and tomorrow you'll receive an email containing a link to the video. The Next Generation Chemical Partnership webinar is on male reproductive health outcomes. A date will be announced shortly. To stay updated and to RSVP, please visit our website at healthandenvironment.org. If you are new to Che and would like to stay updated about upcoming events or more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website at healthandenvironment.org. Additionally, if you appreciate these Che partnership webinars bringing you the latest environmental health research for free, we encourage you to support Che's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers, Dr. Conry, Dr. Varshansky, Dr. Vikstrom, and Dr. Ding for taking time to present today, and to you, Karen, for your excellent moderation during the Q&A. Thank you so much for joining us. Stay well and healthy. Have a great day.